Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers, and today our topic is Safer Supply, a harm reduction tool that involves making regulated pharmaceuticals available for people who use drugs. I talk with Danielle German and Becky Genburg, two researchers from the Johns Hopkins Bloomberg School of Public Health, about Safer Supply and its role in a larger strategy to address the opioid epidemic. Let's listen. Danielle German and Becky Genburg, thank you so much for joining us. We've been covering overdose prevention on the podcast, and in the past, we've talked about strategies for treatment like methadone and buprenorphine. We've also talked about harm reduction like safe consumption spaces. And today, we're going to talk about another strategy in the harm reduction toolkit, Safer Supply. But before we get to what Safer Supply actually is, I want to kind of set the scene. So to start off, Becky, can you talk to us about the current drug supply and why it is so particularly dangerous right now?
Thank you, Lindsay. I think it's a really important and great place to start this conversation. As you know, we have an overwhelming overdose crisis in the United States with, losing consistently now more than 100,000 people every year. That's about 200 people every day. And we're to the point where 40% of Americans have lost someone to overdose. So stated really plainly, the most proximate cause of this overdose crisis that we're experiencing is that the drug supply that is available to the 2 million people in this country who use drugs is contaminated, it's poisoned, it's unpredictable, and it's increasingly so with every day. So if we get one point across today, we hope it's this, that people who use drugs in this country have very little control over what they're actually using. And that's both in terms of composition, like what's actually in the drugs that they're using, and in terms of the dosing. So how much of any specific substance is in what people are purchasing and using. And we have a whole regulatory system in our country in the US. It's meant to regulate the products that we consume and make sure that we're safe when we consume them. But this is a situation in which we have no regulation. People who are using drugs are essentially playing Russian roulette every time that they use. The idea that the drugs that are sold on the streets in this country are mixed with other substances, this isn't a new phenomenon. Like drugs that are sold on the street have always been mixed with other products. That's usually to bulk them up, to lower the cost, to maximize the profits to the dealer. And these are usually innocuous things. So you can think of things like baby powder, like seemingly innocuous. But even if these are innocuous things that are added to the drug supply, it's really concerning for people who are using drugs. They don't know how much they're actually consuming. And this is when overdose is most likely to occur. And in terms of composition, it's really important. We can't underscore this enough. People who are buying drugs on the street from someone who they themselves might have no idea what it is that they're selling, let alone how much it is. It's just incredibly dangerous. And the drugs that are sold in today's markets are very likely now to contain things that are not only just innocuous to add bulk, but also things that are themselves psychoactive substances that can contribute to overdose risk. And so this is where, we've all heard about illicitly manufactured fentanyl, and these synthetic opioids are in the marketplace largely because they're cheaper. They weigh less than heroin, but they're incredibly potent. So they're over 50 times more potent than heroin. And what we can expect in this kind of unregulated market is that something else will always come and take the place of what's there. So these markets are continually evolving. There's always a new substance which people are unaware of. And, we can point to examples like xylazine, like nitazines. These are new drugs that are emerging, and people are just unaware that they're in the drugs. They don't know how much. So really the takeaway point is that the market is really this unpredictable because it's unregulated, because people are unaware of what's in their drugs and how much of what they are using is actually in the substance that they've purchased.
Is it safe to say that we don't really know what, say percentage of the drug market is tainted, but we know it's a substantial enough amount that that's what's kind of contributing to this rise in overdoses?
Absolutely. We can see this in our overdose mortality data, right? It's told us the horrible story of fentanyl, the increasing presence of combinations of drugs that are in our postmortem data, including drugs that were never meant for human consumption. Like I mentioned, xylazine. This is an animal sedative, has not been approved for use in human populations. And yet we've seen in our research in 30 to 40% of people who are using fentanyl, they're also reporting that they detect the presence of xylazine, or we've seen it in their urine. We also see it in drug alerts. These are from surveillance sources, which are highlighting, ongoing concerning trends and emerging threats to the drug supply. So these are places where we can tell that things are different now from what they were prior. And we also hear it from people who are using drugs, like people who are in our community, people who know people who use drugs, who work with people who use drugs, who love people who use drugs, are talking about this broader sense of fear and despair about what is available to them and what their options are for keeping themselves safe.
We have some tools to prevent overdoses, but the unreliable supply has made it more challenging for them to truly meet this huge problem. Can we talk a bit about some of these solutions?
Absolutely. So, starting point, we of course want to emphasize there are a number of critically important evidence-based solutions to overdose prevention, as well as strategies for treatment options for people who have opioid use disorder. And we need to be doing everything in our power to ensure that we are expanding access and availability of all of these solutions. And the overdose prevention solutions include things that are intended to give information to people who are using drugs about the composition, again, of what's in their drugs. There's also strategies that are meant to reduce mortality. So once an overdose has occurred, and these are critical, but again, we're missing kind of the primary prevention strategy that would directly target that drug supply itself. So again, the key takeaway here is that we have these unregulated drug markets. It means anything goes. We don't know what's in the market. We have no idea what's coming next. And because a lot of our solutions were sort of designed with respect to prevention of overdose, with respect to opioids, we're always going to be kind of a step behind in terms of responding and creating these solutions.
Let's look at testing of the supply, for example. Why are test strips maybe not enough to protect all people who use drugs?
So great question. So again, we have these efforts that they're meant to prevent overdose from occurring. And this is through increasing our knowledge, right, about what is in the drugs that people are using. So these are things like test strips. So someone can test their supply of drugs for the presence of a specific substance, and they can receive a rapid result as to whether or not that specific substance is in the drugs that they're using. But I think the issues here should be fairly obvious, kind of considering what we've already talked about. So the test is usually only telling you about the presence of just one particular substance. So we have test strips that, are widely used for fentanyl, also for xylazine. But again, it's only telling you whether or not that substance is present, a qualitative result. It's not telling you about how much of that substance is present in your drug. So it's a yes, no. Again, it's useful information, but it's not complete information. And the other thing is it's only looking for the drugs that we ask it to look for, right? So we don't have solutions that are going to provide information about what else may be in the drugs that people are unaware of that they're using. There's also, drug checking services, and this is where you can sort of drop off samples and have your drug supply tested in terms of the full scope or composition of what's included. And these are really great. It gives us a lot of information about what in the local drug supply, but it's sort of limited in terms of the practicality of the approach, in terms of every time you need to use, it's going to be a barrier to being able to use these kinds of services. So we've talked about these strategies that are designed to give the person who's using drugs more information. We also have strategies that are meant to prevent mortality once an overdose has occurred. So naloxone is a medication that reverses overdose due to opioids. It's an opioid agonist. This is a critical component of our overdose prevention toolkit, and access to it should be widespread so that it's always available when it's needed. But again, this is an approach that's meant to prevent death once an overdose has occurred rather than preventing the overdose from occurring in the first place. But we also have strategies or solutions to support people who want to stop using drugs. And I think among these approaches, the most effective is medication for opioid use disorder. So here in the US, that means methadone or buprenorphine. So medication for opioid use disorder has been shown to effectively reduce overdose among people who are using opioids, but we know that the medications that are currently available may not fully meet the needs of all people who are using drugs. First, we know not everybody's ready or interested in treatment. And every day that they continue to use, they're putting their lives at risk being exposed to our unregulated drug supply. So we need to have solutions in place, depending on where people are, to be able to meet the needs and to keep them safe. And we know that retention in these programs or engagement in these programs, it's a huge challenge. So just like any other treatment or medication, the same thing doesn't work for everybody. People need to have multiple options. We need to think of this more like a continuum of care within which we're sort of meeting people where they are and offering solutions no matter where they might be in terms of being ready to engage in treatment, in terms of their own recovery. And we need to have solutions at every stage of that continuum to keep people safe from the harms that are in the drug supply, no matter where they are.
Given we have a very unsafe supply, opioid addiction is so rampant, we need another alternative, another tool in the toolbox. So let's talk about safer supply. Danielle, could you walk us through what safer supply is?
Yeah, thank you. And thanks so much for this conversation in general. Just to start, we are thinking of safer supply as a missing piece in the sort of U.S. comprehensive response to overdose. That's our starting point. What it is generally it's an approach that is designed to protect the lives of people who use drugs and support their well-being. And the premise is that it is actually possible to prevent overdose by providing substances of known potency and quality and purity as alternatives to what is otherwise completely unpredictable and toxic and the only thing that people have available. So safer supply programs in particular are models where healthcare providers are prescribing regulated pharmaceutical grade alternatives to people who use drugs with an explicit goal of keeping them alive and improving access to health and other services.
All right, so let's talk about what this model actually looks like. Right now, it's only existed in Europe, but we do have models to look at. How does this work?
Yeah, so I'll start by just saying that this is a program that is not currently happening in the US, but it's definitely not a new idea. So there have been European models, as you say, of prescribing drugs for specifically this purpose, stretching back almost a century. And in their case, kind of most commonly, it's programs that actually are prescribing heroin in observed daily doses, primarily to people who have already tried other forms of MOUD or traditional forms of treatment. That's an idea that might raise some eyebrows, but in fact, they have studied it fairly intensively. And so there's a broad base of evidence that we can look at from a number of different European countries with slightly different implementation models, but the sort of general idea that is consistent across the studies is that the programs have really positive impact and in certain ways can actually be better than traditional treatment models, having really high retention. So people who start the programs stay in the programs and they successfully reduce the use of illicit drugs. And then with continued engagement in the programs, they see reduced criminal activity and improved mental and physical health. So there's also a model that has been implemented across Canada, expanded pretty dramatically and deliberately during the course of the pandemic. In those models, most often it's healthcare providers prescribing hydromorphone in settings that have wraparound health and social services. They work with individuals to identify sort of a collaborative dose determination so that it's clear that what is being provided actually matches somebody's level of tolerance and it actually meets their needs. The medications are dispensed daily, either in a model where people are then observed using it on site or in a lower threshold take-home model, which often then is offered as a sort of companion to a daily dose of another form of long-acting opioid like methadone.
So this was happening in Europe and Canada. It took us a while here in the U.S. Our whole approach to the opioid epidemic has really been a focus on treatment, which has had its own limitations. We only really just got what I would call widespread acceptance of an overdose reversal tool. I think the idea of prescribing people illicit medication so that you are continuing to have people taking illicit medication can be a little hard until you realize that the ultimate goal, it sounds like, is just to prevent overdose deaths. Is that fair to say?
That's absolutely fair to say. And then in the process of preventing overdose deaths and keeping people alive, we're also then creating opportunities for people's overall health and well-being to be supported. And what we've seen in the range of evaluation studies, I mentioned the sort of range of evidence that's available for the European implementations. There's also 5 years now of evidence generated from the Canadian implementation that gives us lots of information about what is actually happening there and what are some of the strengths and specifics that they're seeing within those programs. And it's really striking. The findings are overwhelmingly consistent that first, these prescribed safer supply models prevent overdose, clearly. And then we see this sort of whole range of other positive outcomes. And so we see improved healthcare utilization across the board, reductions in emergency department use, in retention, in HIV care, in access to hepatitis C treatment and support and treatment for chronic conditions that people haven't had support for and then are sort of staying engaged in these settings. And then maybe more importantly, people's lives also improve more broadly. And so people describe really powerful impacts on their ability to maintain jobs and housing. Relationships are improving, better quality of life, sort of overall indications of reduced participation in criminal markets, and they're staying engaged. So it's clearly something that people are interested in, willing to participate in, and in fact are experiencing as a really positive aspect of their lives, in addition to keeping them safe from overdose.
I like that you all mentioned that this is really part of a broader toolkit in the spectrum of addiction. You know, this is not the answer to the opioid crisis. This is just yet another solution that we have. And we are not in the U.S. in a place where we should be turning down any possible solutions. So, Becky, I'm going to go back to you. If we were to bring this model to the U.S., what would we need in order to study the efficacy as part of the broader strategy? What would we need to know? What we need to see?
It's exactly how we're thinking about this, Lindsay. So I really appreciate the question. You know, we're at the point here where we think that this should be an option on the table in the US, and we want to start conversations about this. And also remember that we need to collect evidence. We have a lot of questions about this approach that haven't been answered yet within the US context. Our US context, we have different drug markets. We have a different healthcare system. We have a lot of things that are different when we compare ourselves to Europe and Canada. So we need to understand how these models might work, who they might work best for, and really start to quantify how these models can contribute to this overdose prevention toolkit that we have, and start to quantify the impact of this approach on our health outcomes. And to do that, we need to hear from people in the US, mostly people who use drugs, but we also need to talk to providers, and we need to hear from them about this approach. And ideally, you know, we're researchers. We want to have a strong evaluation plan in place before we do anything else. So we want to know if we would see similar positive outcomes in terms of retention and reduction of illicit drug use and exposure to our drug supply that we've seen in other settings, and make sure that we can collect that rigorous evidence in order to support this approach going forward. And if we truly can kind of start to chip away and protect people from overdose.
Last question for you, Danielle. Are you concerned safer supply will make it easier for people to misuse drugs?
Of course, it's something to protect against, and it's something that has come up in lots of different types of programs. And we've learned a lot about how to prevent medications from being in hands other than those that are being directly prescribed. What we know is that it's important to have strategies in place to protect against medication diversion overall. And we know a lot about how to do it. So the evaluation strategies, it would be really important to be keeping a close eye on all of the sort of potential unintended consequences and make sure that we're building evidence and understand what is actually happening. And I'll just add that we've been having conversations with people who use drugs here in Baltimore overall about this approach. And first, I'll just say that they've been incredibly receptive to the idea and pretty immediately describing ways that they think that it'll help them stay safe, improve conditions in the community. And they've been really thoughtful about, are there concerns to worry about? And they have raised this exact question: would it make people who are not already using drugs start? And in their words, if somebody is going to use drugs, they're going to figure out how to use drugs, whether this type of program is there or not. And right now, when that happens, they're facing an unpredictable contaminated supply that can kill them. So the evidence that's available doesn't suggest that safer supply is contributing to increased use within the communities, but we have this overwhelming evidence that the contaminated supply is contributing to our overdose crisis. So there's more we can do.
Well, this is a very interesting and important conversation to have in the theme of preventing overdose, as you say. Danielle German and Becky Genburg, thank you so much for joining us on Public Health on Call.
Thank you, Lindsay.
Thanks so much.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Cesiri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.